Hi, I'm Nadia Masterson. I'm the Director of the Partnerships Program here in the Commission on Excellence and Innovation in Health. And I'm really excited to join you today for our Series 7 of the Improvement Showcase. I want to begin by acknowledging that the land we meet on today is the traditional lands for the Kaurna people. This is the land I meet on, and that we respect their spiritual relationship with country. We also acknowledge the Kaurna people as the custodians of the Adelaide region and that their cultural and heritage beliefs are still as important to the living Kaurna people today. And I'd like to acknowledge the lands that each of you meet on today if they're not those lands of the Kaurna people. So for those of you who are not familiar with the CEIH, we are the Agency for Innovation and Healthcare in South Australia, and our job is to bring consumers, clinicians and community members together. We've got a very small aim of creating better healthcare for South Australians, so we aim high. And we look to do this by imagining new ways to create that better healthcare and acknowledging that better isn't always excellent, but we commit to measuring and making those improvements as we go. That's really a little bit of a theme for where we are today. So in terms of what if the big idea was connecting the small ideas, that really is the essence of how CEIH works, but also the essence of these improvement showcases. We want to bring people together and connect South Australians like yourselves to hear from one another, to learn what went well, sometimes to learn what didn't go so well, because they're almost as important lessons. So just a tiny bit of housekeeping. As you may have noticed, this presentation is being recorded. We share that widely on our website and through social media. But if it makes you feel more comfortable, we will stop the recording at the end of the presentation, which will allow some relaxed questions and answers. So just kicking off. This is Series 7. So our topic for Series 7 is cross-agency collaboration, which is very dear to my heart as the Partnerships Director. And yes, last week we heard from Brett Manuel from DPC, who spoke about Better Together. And today we're really excited to hear from Damon Fenech, who's the Youth Mental Health Co-Lead at NALHN. And he's going to speak to us about integrating youth mental health care. So I'm just going to stop sharing screen and hand over to Damon.
Okay, thank you very much. That means that I need to share my screen now. So let me commence this process if I can. Lovely. Okay, so welcome to today, and thank you for giving up your time today to join this, this showcase. The Commission on Innovation and Excellence in Health, in naming maybe the big things and the small things brought together, is exactly what we have been up to in the Northern Metropolitan Adelaide area. So my name's Damon Fenech. I'm a mental health nurse by art. And this will be a whistle-stop tour of how we've developed an integrated youth service in the Northern Adelaide metropolitan region. And it will just provide a taste of what we've been developing, hopefully in order to pique your interest for the questions and healthy discussion that follows this. And I will say, although I'm the one presenting today, this has been achieved. What we've achieved has been through the hard work and dedication of many people, the same values and principles on which the service stands. If there are some people here today that want to pop on their cameras and say hello, please feel free to do so, but there is a slide at the end where we can introduce you. The journey is by no means complete, and we are on an evolutionary journey to improve what we provide to help and support people who seek our help at times of need, and making sure that they get there to the right service in the shortest possible time. We've already done the acknowledgement of country, which I would like to do again, and the Multi-Agency Integrated Youth Mental Health Service, Northern, acknowledges the Kaurna people as traditional custodians of the land where we proudly work and deliver health and wellbeing services. We also honour Kaurna elders, past, present and emerging, who recognise Aboriginal cultural authority and their ongoing spiritual connection to country. We also acknowledge that at no time were the First Nation lands ever ceded. So, in starting any journey, we need to look at what needs improving. So, in this case, there was a number of things that were happening all around about the same time. And diversity of mental health care needs within a population has been increasingly recognised by the governments, both state and federal. And the population modelling has led to the formulation of a steps model for mental health care in Australia. And the picture you can see there is the first iteration of that. It assumes that a large number of people have transient and milder mental health problems at some point in their life, whereas a smaller number of people have moderate to severe problems. This has then driven new forms of mental health services being designed and commissioned over the last 10 to 15 years, predominantly more so in the area of primary health care, funded by federal government. For our purposes in the North, we looked primarily at the key providers for youth mental health, and these were Headspace Early Psychosis, the Emerge programme, and NALHN Mental Health Services. And this element of funding has provided a more diversified mental health sector than it was a decade ago. And the plethora of providers funded to service specific populations have gone into segments over the stepped ladder. It is notable, however, that the step model promoted by the Department of Health, it remains a work in progress and is continually undergoing adjustments. And this is evidenced by a shift from a diagnosis-based determination of service need to the current transdiagnostic model based on required service intensity. And it's that service intensity aspect that we really have developed in the Northern Metropolitan Adelaide area, so that we are looking at somebody, say, with schizophrenia, requiring at certain times different levels of intensity, either from their GP or from an acute specialist service, but they should all be interlinked and they should all be working together in that space. To support those changes, clearly at that time and continuing, is community feedback. And that community feedback has been in various different ways. Certainly, things like the Victorian Royal Commission or productivity report really spotlighted how not so well we were doing in the eyes of our community of carers and young people, which also led to that political crossbench, political will to improve services. So regardless of whether you're Labour or Liberal, it was something that as a country we were focused on. So, as I mentioned, the services we identified in the North were Headspace Edinburgh North, which would fit into the Step 3 mild to moderate, Emerge, which was the Youth Enhanced Service funding from the government, which is a Step 4 moderate to severe level of care, with also some complexity of care in the primary setting. Headspace Early Psychosis, which in itself is identified as a Step 5 specialist care. However, because they're involved in ultra high risk and early interventions, we'll also see people that would not necessarily fit in a level 5 service, but for their presentation intensity of need, but actually provide that across the spectrum. And then there is the child and adolescent mental health services, who are from infant to 16 brackets or 18 in the North, which are that acute and specialist level of care, which are there in regards to transitioning for ongoing care for adolescents who need more than the door being closed at 18 years of age at midnight, but actually needs to transition into an adult or an emerging adult space. And then finally, there is the Northern Adelaide Local Health Network, which has a youth-specific stream within its community services. The next slide will show what people probably hear a lot from their consumers and carers in trying to navigate our system. The steps at the bottom, they're not particularly well joined together. There's usually referrals backwards and forwards, and so if you're lucky, you hit the right service. It is self-explanatory, But the thing it screamed out to me is that we should stop looking for the Goldilocks patient, the one that is just right for the service. So we need to look at the whole cycle of care for each individual person that is seeking help. Moving on, we need to design something to actually address those improvements. And so in the North, we looked at identifying the priorities, and there were 3 key ones that came up. Now, being a Yorkshireman, I pride myself on a word and a handshake, and that's usually enough in life. And I'm a little bit of a dreamer, and I've been told that by many people. But in business, it's often not enough. At the start, there's great goodwill, motivation, and a common cause for all those services that I've actually identified earlier. However, the thing that actually bound us together and really committed us was service level agreements and memorandum of understanding. And that cemented the goodwill, but it also enabled the continuation of the development when key people moved on. So when CEOs changed or crews changed or executive leads changed, those service level agreements were in place to enable continuation and handover to the next leaders. The second part is really key, and it's a real challenge. It's a common language. One of the things that we found is that we're all in health, we're all trying to help, but we don't have a common language. What's high risk to you may be low risk to me, depending where you are in that step model. The disengagement of a young person from our services may be seen as that person making a choice, but also it may also be seen as we're doing something wrong. So getting a common understanding and language helps us to actually know that we're on the same page. And the thing that did that for us was the PHN Initial Assessment and Referral Decision Support Tool. A bit of a mouthful. There is a link on this slide for you to have a look at if you're not too familiar with it. I'm not going to go into any detail, but the 8 domains within that decision support tool, so commonsensical, everybody in the services went, oh yeah, that's what we do. Or, oh yeah, if we actually try and help somebody in that space, we would really struggle. So actually that also helped us to identify who can offer what, where and when and how, and what the limitations were. The last one is an absolute a no option for me, which is human-based design. And the human-based design approach on its own, oops, I think I've just done. Yeah, human-based design approach is something that there's many iterations of. But what we did in the North is we actually hung that design process on the integrated practice unit approach that's developed by Porter and Lee in 2013. Again, I'm not going to go into detail here, and the links are in the slide to actually have a further look at that. But what that enabled us to do was actually guide us in developing the services and not only listening to what our community needed, but hearing what they needed. There's a real subtle difference there. And this human-based design approach keeps us accountable and true to those people that we're here to serve as public servants. So, implementing it. This is the easy part. Again, some key ingredients, and I do apologise for the busyness of the slides, but I think some of these key things are really important just to touch on. The key mapping exercise that we did at the beginning ensured that each service knew what the other one had and was capable of. So what were the resources? What were guided by contracts? What were guided by expectations? And who can, who can do what? And how can we share and provide the best available care and treatment to an individual, regardless of where those resources were? Now, agreed inter-service collaboration was fantastic from NALHN and Sonder and the PHN's point of view, where we were able to actually identify that in primary care, access to psychiatry is nigh on impossible. It's a real struggle for them. So we had psychiatrists. So why don't we share? So we're able to give up some psychiatry time to Sonder, to Emerge and Headspace. So it prevented the need potentially for referrals and movement out of that service. Also, in NALHN, we had a dearth of specific staff that were trained in specific youth-based care. So actually, in working in partnership and sharing that resourcing actually improved and upskilled our staff to help them work to top of scope. And with that, we also were able to bring on board a youth coordinator to be able to pull this all together, who was a Sonder employee coming to work for NALHN under a shared agreement, which was the catalyst to bring this all together. And I can't speak highly enough of those brave souls that stepped into that breach to be able to go where no other person has stepped before and really walk into the fire and bring it all together. So, and what that enabled then was the intensity of transition pathways. We'll come on to this a little bit further, but most young person's journey through our services requires a referral and a reassessment and a plan or a rejection. We wanted to iron out those services, those pathways, sorry. So ironing out the kinks, moving those hurdles was something we all agreed on. It was required, and we wanted to change that speed of response from acute high risk to an early engagement approach, because usually we're getting somebody instantly if they are really high risk, whereas why aren't we involved earlier so that person isn't in distress, isn't suffering, isn't requiring a high intensity level of service when we could have done something right at the beginning. It was about going towards other services as well as other services coming to us. And now, please don't go off and make a cup of Yorkshire tea, because I'm about to talk about governance. It always sends most people to sleep and they wander off, turn off the cameras, get a cup of tea and come back when I finish talking. But it is vital, certainly in a multi-agency approach, that the line of sight for the young person and for their carer or support is absolutely clear for them to see. So if we've got three services working together with our young person, who is the lead service? Who is taking on responsibility, pulling that together, working together with that young person? So we've really struggled with this, but at the moment, we've got a 4-level framework, which we have a higher level committee, which reports to all the agencies' own governance committees. We have an innovation and operations committee, which all the clinicians and clinical leads and the people that do the real work, not like the leaders that sit back and watch it and take all the credit, but the real cold-face workers actually say, we tried this last week and it didn't work, what went wrong? Or we've been doing this for a long time and it's not really working, how can we do it differently? And then we also have to support that the Northern Youth Mental Health quadruple C, which is Consumer, Carer and Clinician Council. They are our eyes and ears, and they are our conscience on our shoulder that keep us accountable and keep us moving in the right direction for the benefit of the community. To support all of this, we also have a clinical discussion group, which is monitored with multi-agency, multidisciplinary, and really look at and follow that person's journey, certainly if they're deteriorating or recovering. Also, if there is a danger of them being lost to service, and we'll touch on that a little bit more potentially in the question and answer. Okay, you can turn your cameras back on now and put your cups of tea down. Excuse me. And so the last two are already, I think I've discussed those already, which is the language and process. The start of this was integrating our consent to share information, utilising information sharing guidelines. It's like multiple referrals and multiple assessments. The young person is asked to provide that. However, if a young person hits our service at any point, they will be asked about the information sharing that they would agree to and the consent to share relevant information amongst all of the agencies and services involved. This is the first contact that we have across everything, and it's the foundation of what we do. And then the integrated referral and assessment process came out of the initial assessment and referral decision support tool, which we'll touch on a little bit later. So here we are as an example of how we do this. Now, don't be scared of this next slide. Don't do a busy slide, so I do a busy slide. We don't need to dissect this slide because really it's quite simple. Every service has that left-hand part here that the referrer, or the GP in this case, will send a young person through. And we need to do this. We have a responsibility to assess. We have a responsibility to ask questions. We have a responsibility to make sure that we are the right service for that person. However, like most things, like we said earlier, if you don't fit, if you're not the NALHN Goldilocks one, we'll send you back to the GP. Great. You may get a letter that supports that journey back to the GP. However, another referral, another process goes on. And so before you get to the service, this can go on a number of times. What we've managed to do within the Northern Mental Health region with Sonder and Headspace and NALHN Youth is we've actually captured what we do. And the integrated referral and assessment procedure is something that we all now do. And from that, we don't have to send back. We can guide them, the young person, to the service that initial assessment actually identifies them. And when I say assessment, it's not a comprehensive or emergency mental health assessment. It's an assessment of need, intensity of need that person requires in order to enable the best outcome for their recovery. And that is really important in a number of services where we can over-service or under-service young people, both to the detriment for that person's recovery. So that process has taken some time. How do we do that? We trust each other because we know the tool that we're using. We know that we're all trained in it in the same way. We trust each other's clinical decision making. And if the clinician supports the outcome of the tool, then why would we do that again? And I'll give you some examples at the end to actually show how this works. I'm looking at time, we're coming up to 20 minutes, so I'll try and skip through these a little bit because they're pretty obvious. But certainly from an evaluation point of view, we evaluate continually in what we're doing. I won't go through each of these, but I will make note of the youth depression study that we're undertaking research with support from Adelaide University, Sonder and the Hospital Research Foundation Group. There is very little research in the area of youth depression, so we are now covering that across the whole of the step care model, step care process, and hopefully we'll get some great information out of that. There are the usual outcome measures and auditing process. What we tend to really concentrate on is the accountability to our consumers, carers and community. That feedback is so valuable to us. The joint training and interrelated reliability supervision actually supports what we're doing at a higher level to enable an understanding of guiding that person through these steps so that everybody knows where what that young person is going to from us. So maybe previously it would have been, you don't fit with us, we'll refer you to Headspace. We didn't really understand Headspace. Doing the inter-rater reliability supervisions and joint trainings, starting to understand what goes on, what happens, how we can work together and support each other in these spaces. And finally, some of the lessons learned. This is the juicy stuff. This is really I could have gone on for 20 minutes just about the lessons learned, but these are some of the important ones. Understanding each other's limitations has taken some time, not only personal and professional in the roles that you're in or the delegation levels that you have, but the actual limitations within that service. So I'm not sure if Josh is here today or Jess is here today, but asking the clinical leads of Merge to make service level changes within their organisation, and they don't have the delegated authority to do that, it's really important to understand and then develop that governance and communication process to know each other, not only as a professional, but as a person and the principles and values within what we're doing. And this one I've taken some time to come to terms with is the contractual and reporting requirements for the service and their funding cycles. I find this personally quite frustrating at times because the contractual requirements of some of our services are laid out at a higher level and don't necessarily fit into the localization of what we're trying to do. And that's something that we're working with both the SA Health and Adelaide PHN, who have been absolutely brilliant in helping us support move this forward. Leaders enabling positive risk-taking is really, really important. What I mean by that is we are the snowplow that actually gets through all the things that get in the way for our clinicians doing the job that they want to do and need to do and working to top of scope. It's ensuring that behind the snowplow, there's nowhere for them to slip up and that we're there to ensure that they don't slip up and catch if there are issues that arise during that time. It's a really key point that us as leaders and executives really need to take on board. I think between the constraints is an easy one. Communication, communication, communication. My goodness me, how the simplest things can create the biggest explosions. Simple things like words, simple things like interpretations of processes, certain things like feeling like you've been left out. These tiny little things can derail what we're doing. So make sure that you communicate in everything that you do to ensure that those little things don't get out of control and out of proportion. And I'm going to come quickly to the don't blame, own and resolve. Many years I've seen people, individuals, services, organisations blame others, blame them for their lack of ability to do their job. Waiting lists are a great example of this. Whereas what we have done in the North is say, actually, the waiting list for Headspace and Emerge, that's pretty bad. However, whose problem is it? It's not our problem as NALHN. It's not really Headspace's problem or Emerge's problem. It's a problem for the young person. So if we're going to work together in a single approach to care and a whole cycle of care, let's own it. Let's not have a waiting list. Let's have a commencement of recovery list. Let's do some demand management. Let's do drop-ins for those people who are waiting for structured therapy. Let's do some education groups outside of the normal process to actually help that person be mindful in their emotional regulation or understand the medication that their GP has prescribed for them. So don't just say it's someone else's problem. Own it. Whether you think it's yours or not, own it and work with the people to actually help the young person that we're here for. So very quickly, some examples of how this has worked really well. Christopher, young man, referred to us by mental health triage to community mental health, depression, anxiety, and feelings of hopelessness. An integrated referral and assessment procedure was undertaken by our clinicians, and a level 4 service need was identified from that decision support. This was ratified by the clinician because it doesn't take away clinical judgment. It's what the clinical judgment is, which is more important. So Christopher was then transferred with an automatic acceptance to the Emerge programme, and then an assessment occurred with the clinician whom will provide the structured psychological care. Now, this is a real case, as with the next one. Names have been changed, but this is the changes we're making. So prior to integration, I think people will actually realise that if they'd come to us at a level 4, we probably wouldn't have taken that on, sent that back to the GP with an advice letter, gone to Headspace, but that hopelessness may have actually indicated some other level of distress, which Headspace couldn't actually manage. No, my high risk understanding is your low risk understanding, and that comes into play there. Whereas the actual journey was triage. To us, the intensity of need was identified, straight into Sonder emerged for assessment and treatment, with no need for re-referral or reassessment. And last but not least, Brittany. A little bit more complex with Brittany, and we often come across this where GP referred for psychiatry assessment of depression. Again, 291's been difficult to access in primary care. The IREP, or the Integrated Referral Assessment Procedure, actually identified some hallucinations being reported, which then fits into the early psychosis program. So rather than going into too much depth, Brittany was actually transferred to the early psychosis program, where the assessment was undertaken, and it was pseudo hallucinations that were identified. Now, from there, beautifully, it was, what does she need? Well, what she needs is some structured therapy for presentation, but there is a level of acuity that's involved with Brittany that needs a higher level of support, which Emerge can't provide. Therefore, NALHN, being that level 5 acute specialist, we partnered with them. We took the lead as the level 5 service, so there was a direct line of sight in regards to governance, but we worked in partnership totally with Brittany. And Brittany was involved in all that decision making all the way through. We talk to people, we give them choices, we give them options, and we tell them what's going to happen next. And we're hoping to move on to not only what happened next, but what to expect from the treatment options that will be available for where they're going to end up. And after a period of time, the acute requirement has been reduced for Brittany. This has been in regards to joint planning between the services and including Brittany herself. She continues to be supported in partner care. This is through shared clinical review and fortnightly interagency clinical discussion forums. So once again, Brittany may have bounced around for a bit before ending up somewhere, but even though this wasn't a straight line, it needed another involvement with a service for an assessment. It was still only one assessment. And that assessment led directly onto treatment. So that's your whistle-stop tour. I'm sorry it took a little bit longer than I expected it to, but going on to, this isn't all about me. Hopefully some of them will introduce themselves at the questions and answers, and the shy ones hopefully will be here as well and provide me with a photograph. So back over to you, Nadia, for some questions. Thank you. Excellent.
Wonderful. Thank you, Damon.
Stop sharing.
Absolutely. Thank you very much. That was a fantastic presentation, and great to see such a complex area addressed by a great group of partners. To that end, those of you who are online, who are from the partner agencies, from Sonder or from Adelaide PHN or from NALHN, please turn on your camera and give a wave and introduce yourselves.
My microphone's still on. Yes, it is. Come on, Peter, don't be shy. I can see you there as well. You've been around this for a while. Oh, I'm Becky. Say hello, Becky, from Space Early Psychosis. Unfortunately,
say hello from NALHN.
Hello, NALHN.
Hi, NALHN.
So thank you so much, Damon. Fantastic presentation. You know, it has been like really wonderful working in this service over the past 6 months, and to see, you know, the impact that especially the you know, the fortnightly meetings, multi-agency meetings we are having on individual consumers who maybe in the past may have slipped through the cracks, or you know, had poor outcomes because of, you know, the lack of communication that existed in the previous system. So yeah, it has been going really well.
That's great. And thank you to Damon for being brave enough to step forward. It's hard when it's a partnership for one person to take the reins and do the presentation. So thank you.
Is that the sacrificial lamb statement? But I want to just follow on with Hannah there. I think one of the things that we haven't been able to do in this presentation, and really it was really challenging, was the benefit of the clinical discussion group that happens every fortnight. Hannah mentioned people potentially being lost to services. There have been real cases where two services looking after somebody closed that young person who was in dire need for help because they moved out of area, which in the scheme of things, yeah, not a problem, moved out of area. However, she wasn't engaged in the new area. And it was through the clinical discussion forum we realised the risk that was actually present for that young lady. And both those services reopened, engaged with the young lady who was out of area, and actually engaged her with the services in her area before closing. That would never have happened without what we were doing. And it's something I'm really proud of in regards to the team and how we utilise the space as partners across the whole spectrum.